Good morning or good afternoon, depending on where you're at in the United States or worldwide. Welcome to the Ross Baruzzini COVID-19 Healthcare Security, what we've learned so far webinar. It's a pleasure being with you today, and thank you for joining us. By introduction, my name is John Desch. I'm the Chief Commercial Officer at Ross Baruzzini, and I'll be your host today as we walk through this. The format for today is I have on with me, and I will ask them to wave at you as I introduce them. The format today is I'll be asking some questions to our experts who will give short answers. At the end of this program, there will be an opportunity for questions and answers. I would ask that anyone who is interested in asking a question, don't wait to the end to type in your question. If you go to the chat box and pose it as a question, we will capture the questions throughout the presentation, and at the end we'll spend whatever time is remaining answering those questions. So by way of introduction, first let me introduce Ben Scaglione. Ben down here. Ben is a Senior Security Consultant at Ross Baruzzini. Ben has been in healthcare security for 39 years. 25 of those at a senior level in some of the largest healthcare institutions, multi-hospital institutions in America, two of which are New York Presbyterian and Bellevue Hospital. Ben, as he will introduce himself in a little bit, has been in those institutions during some of the largest traumatic events in our history, certainly 9/11 and maybe some Katrina and other types of events. So Dan is here with that level of experience. I'm sorry, Ben is here with that level of experience. Dan Morro, if you could wave at everyone, Dan. Dan Morro is a DHS expert at Ross Baruzzini and Principal Security Advisor. Dan brings more than 25 years of local, federal, and international law enforcement and security experience. Prior to coming to Ross Baruzzini, Dan served as a senior member of the U.S. Department of Homeland Security Investigations Division in Chicago field office, and spent significant time in similar roles in Western Europe and Africa while stationed in Paris. Dan is also an attorney and brings significant experience in understanding healthcare security and security and threat assessment in total. So with that, I'll start by asking some questions of our experts. Again, if this brings up any questions in your mind, please send them in quickly. So first, Ben, you've dealt with multiple emergencies throughout your healthcare security experience, many in the Northeast. How is the COVID-19 event similar or different in what you've seen and learning in this process?
So John, you're right. I've gone through a number of emergent events in my career, but I wanted to talk a little bit about a different kind of event that occurred in 2009. I had the opportunity to work with the New York State Health Department when they conducted a statewide pandemic tabletop. They did that as a result of the SARS and the H1N1 outbreaks. The health department wanted to develop a program to effectively help hospitals respond to a mass exposure incident like a pandemic. The tabletop was followed up by a series of meetings to develop a plan to effectively respond to the pandemic. As a result, there were three major takeaways from the tabletop. Obviously, the first one was supply chain, getting supplies into Manhattan and obviously into the hospital. Staffing levels, staff became sick, couldn't show up for work. Their family members became sick, and they stayed home rather than going to work. And obviously the third was patient surge, something we really couldn't resolve during the tabletop and follow-up meetings. However, as a result, our hospital did purchase some temporary hospitals that we could have put up during the pandemic. For security, the biggest challenge was really locking down the hospital. I got to be honest, there were doors in our hospital that hadn't been locked for decades, or even from the beginning, when the hospital first opened. We did that, or put that process together, because we anticipated staff not coming to work because they became sick, or again, because their family members became sick. We realized we needed to do more training for PPE for the security staff, and obviously we were going to teach them how to use a thermal device to take temperatures. We also reevaluated the triage area and how we'd screen people coming into the hospital. As a result of the tabletop, we reviewed our emergency preparedness plans and our security needs. So I brought this up because I think we still have a lot to learn when it comes to pandemics. Obviously, 10 years ago, we went through the process and learned a little bit, but I think we need to learn more. I think we need to reevaluate our systems and processes and better prepare for future events. But I think, John, overall, we can do more to be better prepared in the future.
Thank you very much, Ben. Dan, would you like to add anything in from your perspective?
Thanks, John. Yeah, prior to joining Ross and Baruzzini, as you mentioned, I spent 25 years with the government conducting federal investigations and operations focused on national security threats. The underlying goal of these efforts being to protect critical infrastructure in the country. I don't think it's been more than spotlighted now that the hospital systems and medical community are under the spotlight and are the focus of that attention right now. So during my time with the government, I had firsthand experience with other natural crisis events, response and recovery, in particular 9/11 and Katrina. And now we find ourselves, as we did then, in another who could have imagined kind of moment. It's when the unforeseeable becomes reality. And as we compare and contrast this event to prior crisis response, there are some obvious parallels, but obvious differences too. So the federal government, one of the things the federal government will certainly be delivering at some point, a set of guidance, standards, and best practices that will then filter down and be implemented accordingly. Whereas prior crisis response allowed for the federal government to have a more targeted allocation of resources. Because of the scope of this, I see this one as different with the pandemic. Really, the emphasis has been put on state and local officials, and that includes hospital executives to lead their own efforts to shoulder the responsibility of how best to deal with this rapidly changing situation. And I think that's the model that's going to continue. And while the exact modeling of what is to follow is not fully taken form yet, it's evident that hospital systems, healthcare systems need to implement emergency planning for something of the scale of this pandemic response. So a quick story, just before the onset of this, actually Ben and I were on a call with a hospital CEO in a major city, and he was relaying a quick story that was became apparent as during a live active shooter event that was happening outside of his hospital. And all of a sudden he found himself thrust into the role of having to be responsible for finding a contact in the city to get information about what was happening and relay it to his staff. I just used that as a story where you need to have these mechanisms in place, because when they do happen, they happen very quickly, and people are going to be looking for answers.
Yeah, thank you, Dan. Certainly things have changed, and healthcare administrators and governors and state and local officials are doing their best to come up with solutions, to think about what's next and what should we do to do the best thing for our communities and our patients. I know we're jumping ahead a little bit, but given the experience that both of you have, I'd like to kind of jump into the question. Ben, what suggestions would you have for hospitals and local officials, given what you've seen, what you know, and what you've experienced? What do we do next? What do you suggest for the population in this?
Well, John, I think we need to start by talking about the next few weeks or the next month or so, and I think that depends where you are in the country. I think some areas, like I am in New York, New Jersey area, we're starting to decline in our number of cases. And that's not true everywhere. There's still some places in the US that are on the increase. But I think whether you're declining or on the incline, I think for the next couple of weeks, it's really status quo. I talked to some of our clients and obviously with a lot of security directors across the country, and they're very stressed. I got to be honest, and I think that's going to continue. But I think those that are on the decline really need to start thinking about the next few months and beyond. I think they need to start thinking about reassessing their plans, looking at what they've done over the past couple months and what they can do, look at their procedures and processes, and also look at how technology can help them provide better security.
I think that's, there's some obvious things that we're all going to do. And I think that's key, a review of our plans to make sure that we incorporate what we've learned in this whole process, not just from an individual institution, but from peers also. And I know that's one of the things that both of you are doing as you speak with hospital administrators across the country, is gathering that peer information, that peer experience. So I appreciate your update. Dan, through your eyes, through your experience, what are some of the things that you think people should be doing? What are your suggestions?
Well, I agree with what Ben initially said. And as hospitals and healthcare facilities attempt to return to some kind of normalcy, it'll be a new normal. Obviously, I don't think we're going back to exactly the way things were anytime soon. It's important to step back and identify the key issues and challenges that each institution faced, and these will be individualized. And they'll also have to be looked at in a community context with our first responders, our law enforcement communities. So this will all have to be coordinated at different levels now. There was such a wide spectrum in the degree to which hospitals have been affected. Some were like MASH units, while others were preparing for surges that haven't come, or maybe actually haven't come yet, because we all know that one of the other looming issues here is the potential second wave and what that may look like. So no community has been safeguarded from this. It's been equally devastating across the board, which makes it different than any other pandemic that we've had in recent times. And as we move away from the initial crisis reaction phase towards more of a mitigation and preparedness measures, I think the first step is going to be an assimilation and a digesting of all the information that's out there connected to the experiences of all the various communities. And equally important is going to be surveying the landscape of other sectors and how they've responded to it. And I think this is where Ross and Baruzzini differentiates itself from other companies in this space, by having global security experience and expertise across those multiple sectors like aviation, rail and transit, higher education, government, in conjunction with the technology division they have, using this diversity to deliver innovative and holistic approaches to the security solutions. So in particular to the hospital environment, our medical equipment planning division understands the functional and operational aspects of hospitals, which provides insights that assist in these security discussions and safety planning. So by way of example, we look at things that are happening in airport technology and processes, and or university dorm procedures, and then can have discussions about ways that translates into the hospital setting.
Yeah, thank you very much, Dan. I want to come back to Ben for just a second and call on your experience and your knowledge of healthcare security. This is an unprecedented event in our history, and certainly something that our children and their children will either remember or learn about. But within the healthcare security community, how is this going to change the healthcare security role in the entire healthcare environment? Are there things that you're seeing that are evolving that would say healthcare security needs to think about these 2 or 3 things, or they're taking on additional responsibilities? What would you say from your multiple conversations?
So, John, I think as the pandemic winds down, hospitals really need to assess their operations over the past few months. But I think first and foremost, I think what's most important for hospitals is to really give their staff some relief. It doesn't matter whether you're a security officer or a housekeeper or a doctor or a nurse. think what's most important when the time is available is to get them out of the hospital situation, get them home, give them time to spend with their family and friends, and kind of recoup from what's been going on. And the reason I say that is that, as Dan indicated, there's also there's that opportunity for that second wave, and we all need to prepare for that as well. I think during that relief time when staff are out and convalescing, I think what's most important for hospitals is really to assess their security needs for next year, and again, as Dan indicated, what the new normal may be. And we're not going to know that until we get further along, but I think it's important to start looking at what that's going to be and how that's going to work. That second wave, as some people have been indicating, could be worse than the first. So that being said, hospitals really need to refocus on security operations, provide or conduct risk assessments, look at long-term planning, and this includes staffing, operational changes, technology acquisitions, training requirements, and of course, emergency preparedness revisions. They also need to really take a look at IT security. I think the new normal, may be more teleconferencing, more telemedicine, and staff working at home. I think IT networks, if that's the case, need to be a lot more secure. I also think there's some new threats out there that hospitals really need to take a look at. I mean, there's been some discussion about conspiracy theorists doing some certain things and radical idealists getting involved or trying to shut down hospitals, whether they're temporary or permanent. And I think, if we go into a second wave, that may happen, or those types of things may increase. I think, we need to evaluate violence. We're starting to see a small number of protests across the country for a number of different reasons, whether it's staff protesting the hospitals they work in, or people just not wanting to be home and wanting to get out and get back into society. I think that we're seeing an increase in domestic violence, and I think that may spill out more into the hospital, affecting staff, and certainly affecting the number of people in emergency rooms. And of course, I think we're going to certainly see an increase, unfortunately, in mental health issues. And I don't think we're currently doing a great job, from a public health perspective on mental health. And I think we're going to start seeing increases in those types of things. But I think we at Ross and Baruzzini really can help a security department start to think about those assessments, looking at those new risks, reevaluating operations, and coming up with threat reduction strategies that'll work in the new normal.
Thank you very much. We're at the point where I'm going to open this up for some of the questions, but while the questions start coming in, and I think there are 2 or 3 as they're coming through, there are some things that are occurring nationwide. One of the things in speaking with different administrators across the country is that, trauma has changed. Certainly hospitals are now engaged in healing or taking care of those affected by this virus. And from a security standpoint, we've been maybe lucky that there have been maybe fewer gunshot wounds and serious accidents, because people are just not out in a way. But as Ben indicated, domestic violence is always a situation we deal with in the security world, and the new normal is going to require a completely different set of security skills and technology and processes. So with that, let's see if we have some questions. I think we have a question here, and I will pose this to both Dan and Ben. Do you feel that telethermal devices can be effectively used to mitigate risk at the healthcare facilities? Let's start with Ben on that.
So John, we've been taking a real close look at that. I've been actually doing a lot of research. There's been a number of studies that were done back in the early 2000s as a result of SARS and H1N1. And a lot of vendors have been jumping on the bandwagon. So we've been taking a look as best we can in demonstrations and seeing what products are out there. I think they can be effective, but there's they need to be set up properly. They need to be evaluated properly. There's some environmental issues. There's some distance issues. There's some angles as to where the device needs to be placed to get the best results. But I think what everybody needs to understand is it's really just one piece of the process. They're not going to be 100% effective. There are certainly a lot of normal things that occur with people that would raise their temperature and give them a positive result when they may not have a fever. And there are certain conditions, and with COVID-19, we're certainly seeing that. In SARS, they didn't see that as much. H1N1, they did see it, but sometimes people can be contagious and not have a high fever. So I think it's something that's going to evolve. I think a lot more people are going to start, looking at that as a device to assist, as a technology to assist security and assist hospitals in reducing the number of staff at an entrance. And I think not only in hospitals, but in all industries, people are going to be looking at that as a way to help provide a more safe and secure environment. So we'll see what happens, but I think it's definitely something we need to look into, and it's definitely something we need to use going forward to help reduce the potential for exposure to a pandemic.
Yeah, and I think you captured an important thing, Ben, in that these technologies are part of a solution. They're not solely a solution, so it takes a holistic view of this. But certainly, those types of devices are going to be more frequently deployed in healthcare. Dan, I'd like to ask you. I know you've been in embassies and airports and all types of places that I can't even imagine where these things are probably already deployed. Do you have some experience with that?
I do, and I echo Ben's sentiments that as the specific technology emerges, I think we need to first look at how any of those technologies can be implemented in an effective and efficient fashion. And from the government perspective, for example, one of the key lessons learned from 9/11 was the need to know who was crossing our borders and gain as much information about these individuals as possible in order to develop risk profiles. Now, that was a marked shift in the government mentality then, and involved a massive reallocation of resources. I would analogize the future of hospital security in the same context. If you look at the hospital as a small city, whether it's a single building or a campus environment, it too will have defined borders. In order to employ these kind of resources, you have to control those borders, and similarly, an emphasis on knowing who enters the facility is of great value in doing that. So taking it a step further, it's going to be equally important to track or confine the movement of people inside the hospital, and that includes patients, vendors, employees, as well as visitors. So I guess the answer with that technology is, how can this be done? And things that we've been talking about, aside from the technology aspects, are the registration process, a pre-registration process, perhaps with questionnaires for all people entering the hospital, not just for patients, limiting entrance-ways and access ways, which Ben mentioned too, badging changes. So whereas after 9/11, the objective became to trace people's contacts for possible terrorism ties, now in healthcare facilities, we want to trace contacts related to contamination and exposure. So the philosophy behind this strategy was pushing out the borders and identify threats before they enter. And I think that's what we're already seeing in hospitals with some of these facilities they have to monitor and test people before they actually enter the hospital, some of these temporary facilities. And that, of course, with the sensitivity of the balance to the patient experience and security, we all have to be conscious of that. And eventually restoring patient and staff confidence, I think that's going to be a major goal. And I think through the security and planning efforts that you can alleviate a lot of anxiety and return to the new normal, as we keep referring to.
Yeah, thank you, Dan. Ben, I want to follow up on that, because we have a question related to Dan's comments. So with everything that's going on in hospitals, patients and staff and other associated people that need to come in and out of the healthcare organization or the healthcare campus, what are some of the experiences that your customers, your clients, are deploying to manage people coming in and out, and tracking, one step farther in securing the in and outs, if you will?
Sure. And prior to COVID-19, I have to tell you, this past year, I've done more work with visitor restriction in risk assessments and design work than I've ever done before. And I think that trend is going to continue. Hospitals are starting to look at turnstiles, metal detectors to restrict or screen people, visitor management systems, as Dan had suggested as well. And I think that's the way it's going to be in the future. A couple of the systems, I talked a little earlier about some of the technologies we were looking at as far as checking temperature, and a number of companies have come out with devices that attach to a turnstile and read your temperature. There's even one company out there that can determine from facial recognition that you're wearing a mask or not wearing a mask, if that's a requirement. And it'll either provide access through the turnstile or deny access and give off an alarm if your temperature is too high, or if you're not wearing a mask. So there's some great technology out there, but I think that technology is going to be part of the new normal. And I think hospitals need to take a closer look at those types of devices and those types of things, and really restrict access so that the care and the structure of a hospital is that the care part is one part of the organization in the back of the house, where employees work and conduct businesses separate, and kept separate from visitors and patients, so that there isn't that mix of people, so that it restricts the ability to transmit a disease. I also think hospitals are going to be redesigned. I mean, one of the complaints a lot of doctors and nurses are having is there's not enough negative pressure rooms within the hospital, and I think that's going to be a major change going forward. I know there were discussions back in the early 2000s about converting a higher percentage of rooms into negative pressure. I think there's going to be a lot more of that going on as well.
Oh, thank you. I have a comment that I want to share from a chief executive officer in the New York City area, who tells us, or asks me to pass on to those listening, that the members of her team that were sitting around the table planning how do we address the COVID-19 emergency are going to be different from the team that's sitting around addressing the problem of how do we recover and how do we move forward. And she's asking or suggesting, as a best practice, what has been learned in her organization, that assess the team of who needs to be around the table in talking about how moving forward, instead of using the same team. And I think that's a good lesson learned, that assess the team necessary to go back to a new normal is different than the team of managing the crisis. We have time for one more question. And I have a question. Will we see new deployed devices at airports, transit areas, federal sites, that are health screening devices, technology, kiosks, for rapid screening of people? This may be at a mall, it may be at a hospital, it may be at an airport or a rail station. Our customers, our clients, is this in the discussion blogs that you guys are seeing? Let's start with Dan, and then we'll go to Ben to finalize.
Certainly, all this is being discussed. What it actually looks like, that's the million-dollar question. And how much it's going to cost is the billion-dollar question. So yes, to answer that question, all these things are on the table and being talked about, and specifically specific to healthcare. I mean, we're looking at a reset. We're looking at a reset of the security posture here. It's going to be changes of behavior. For example, if you look, 9/11 resulted in dramatic changes to the airport security procedures and eventually the public accepts it. If you asked 20 years ago what it looked like going through an airport, most people couldn't even remember it now. So I think we need to use this as a platform to change the way that hospital security posture looks in general. It's going to be a convergence of, Ben mentioned it, it's going to incorporate cybersecurity, it's going to incorporate the physical security, it's going to incorporate the pandemic planning. And there's a way to leverage all these in a more efficient manner. So that's where I think we're going. And technology will be a big part of it. It's just going to be how you use it and how efficient it's going to be.
Thank you. Ben, would you like to add anything before we close?
Sure, and you know, I kind of agree with Dan. I think all those things are on the table, and I think they're all being looked at. I also agree with Dan that I think in healthcare we're going to see a reset, and I think that reset's really started prior to COVID-19 when it comes to screening people and access control, and I think we'll start to see more of that. And going forward, and again, you know, I think that's something that really needs to be assessed. It really needs to be, you know, looked at to see if it fits the culture of the organization and how the organization works. And again, technology needs to be reviewed as well. You know, that may work for some institutions and not work for others. So I think that process is really important. I think that hospitals really need to look at security from a long-term perspective. You know, again, security tends to cost money. It doesn't bring in any revenue. And I think what's most important in the process of redoing or reshaping security in healthcare is to really look at the long-term, the budget requirements, the costs, and what it's going to do for you or where you need to go over the next 2, 3, 4, 5 years. The other thing, John, I really wanted to say, I wanted to comment on on your comment about the hospital administrator and the team idea. And I think they're absolutely correct when it comes to having a team approach. I think that's really important as we start to relook at what's healthcare security is going to be in the next year, in the next 2 years, in the next 3 years. And I think security directors as a whole are going to be really, really busy dealing with staffing issues, implementing and changing policies, reviewing emergency preparedness procedures. And I think as part of that team, and I think they should have a team of experts to help them, you know, do this right so that it's cost effective, it's efficient, and it provides a higher level of security. And I think it would be best for hospitals and security directors to really think about having an expert, someone who's gone through this process and maybe is part of the organization or maybe isn't part of the organization, to help them go through this change and again, you know, provide that long-term planning. And that's something that we're really, really good at Ross and Baruzzini, is really that long-term master planning and technology evaluation. So it's something for that team to consider bringing in that outside expert.
Oh, thank you very much. I want to thank Ben and I want to thank Dan for taking the time today, and especially I want to thank our audience for participating and providing good questions and comments to this discussion. Obviously, this is something that was titled "What We've Learned So Far," and it's not over. So there's going to be a lot more that we may bring to you as our learning continues. But again, I want to thank everyone for their participation today, either as an audience or a presenter. A video recording of this will be provided on the Ross and Baruzzini YouTube channel in a short period of time. If anyone needs any additional information or would like to speak to Ben or Dan personally, please reach out to us and we'll set something up for you to have a conversation, knowing that there's no way possible in 31 minutes we can get all the questions and all the comments answered. I appreciate it. Thank you very much for your attention, and we look forward to speaking with you soon. Take care. Have a great day.
Stay safe, everybody.
Take care, everybody.